Hi, everybody, and welcome to this episode of Bringing Care Home. Today with me is the CEO of Inbound Health, Dave Kerwar. And Dave, you read your bio on the internet, and you've got this fascinating career with payers and providers and innovators and investors. And so we're really interested to hear about you. Welcome to the podcast.
Thank you, Kathy. Thanks so much for having us and learning more about inbound health.
Excellent. Well, why don't we start with you and tell our audience about you and your journey, in your professional life towards inbound health.
Yeah, definitely. I've been in healthcare for about 25 years now. I am not a physician, always on the business side. I started my career in the engineering side, building innovative technologies, initially to help hospitals from an operational and a supply chain perspective. And then over the past sort of 10 to 15 years, have been really focused on bridging the gap, typically between health systems and payers. So as you mentioned, I've been on both sides to help really try to achieve the triple aim. To innovate on the care model side and on the payment model side, to try to bring about a more patient-centric care model, and a payment model that lowers costs but increases efficiencies for all parties. Prior to starting Inbound, I was the chief product officer for Mount Sinai Health System in New York. Mount Sinai has and continues to do some really innovative activities directly with employers and payers, and most importantly, consumers, to try to innovate on the care model side to bring care closer to the consumer and in some cases to the employers. I was building a technology enabled solution there to really help scale a lot of their direct to employer and direct to consumer care models. Prior to that, I was at Aetna, helping to build and launch our joint ventures. So we were building joint ventures with health systems that were half owned by Aetna and half owned by large major health systems, with the idea of really integrating the care model and the payment model between those two parties, with the goal of truly lowering costs and taking costs out of the system. So pretty excited and continue to be pretty passionate about that aim in my career.
Neat. Well, I've always been kind of so dedicated and fascinated by this. Anybody who's trying to get, right patient, right care, right place, right cost, it's got like the right thing to do, right? Tell us how you ended up at Inbound Health.
Yeah, you know, partnered back in June with Allina Health System and a venture capital firm out of Boston called Flare Capital Partners, because Allina, for its part, had developed a really innovative and impressive and scaled advanced care model program in the home, really focused on hospital replacement, where they were taking patients that were presenting typically in the emergency department, and their clinical profile and their functional profile was such that patient could receive their hospital level care in their home. They'd also launched really what we call a sniff at home care model, where they were typically meeting patients that had already been admitted into the inpatient unit, and they could be discharged a few days earlier. And instead of going to a brick and mortar sniff bed, skilled nursing facility bed, they could receive their skilled nursing facility care in the home. And so we saw a huge opportunity to scale this type of care model beyond Allina and to health systems nationwide. Working with Allina and working with the team there, as well as the Flare Capital team from a financing perspective, we launched Inbound Health. And Inbound's vision is really to partner with health systems to enable advanced care models in the home. So we've got our acute hospital at home program, which again sort of replaces that hospital visit, as well as what we call our elevated care at home program, which really takes what would have been a skilled nursing facility, a brick and mortar skilled nursing facility visit, and brings that care into the home. We've been doing this for the better part of 3.5 years now, and have cared for over 8,000 patients across 350 disease states. So while we started this business and started these types of care models within the confines of the pandemic, we really have expanded it to a number of different disease states and to a huge swath of patients. You know, when you think about inbound, what we do is we partner with health systems and we bring what we like to think of as the full stack of capabilities that a health system will need to launch and scale these advanced care models. So the care model itself, so the clinical pathways that are integrated into the clinical and operational workflows of our health system partners, a proprietary technology and analytics platform. We've realized over time that it's really difficult to just reuse sort of an off the shelf biometric monitoring platform for these advanced care models in the home. You really need something that's really custom designed. And we believe we've done that in our platform in home. A virtual command center. So we have a staff of biometric monitoring nurses, triage nurses, and then virtual hospitalists and SNPists that are rounding on patients on a twice, sometimes more than that, daily basis. Supply chain and logistics. So in these care models, one has to bring in everything from home infusion, in-home labs, imaging, DME, the non-emergency medical transportation, nutrition, and so we enable that. So we partner with typically either local, regional, or national partners that can bring that into on behalf of our programs, and we manage and coordinate those partners across the episode. The in-home labor component. So we bring whether that's in-home nurses, therapists, or community paramedics. We bring that to bear if the health system doesn't have access to that talent base. And then finally, payment model. So as I think probably most people know, there's a waiver program that CMS set up that's strictly specific to hospital replacement. We enable that, but we also work with our health systems to help them negotiate typically case rates and moving more into value-based care contracts with their regional and national plans in their market, typically focused on the Medicare Advantage population and managed Medicaid population. So we really bring that full stack of capabilities, but we focus with health systems to be flexible too. Some health systems already have some of those ingredients. Maybe they've got an existing remote patient monitoring program, or they've got one of a different type of advanced care model program. So we can leverage the capability set they already have, and then inbound for its part comes in and sort of fills the gaps with our capability set.
Yeah, well, and really interesting. I've spoken to you before, and to your COO Julia Christ, and some of those Allina folks, including Dr. Downing, and just really innovative because you're saying, hey, we'll meet you where you are. You got a model already. We'll bring our skills and technology to bear, and work with you on that. If you've got nothing and you want us to do it, we're going to do it that way. And I think that's fascinating because I think it gives people health systems a way to say, well, yeah, let's have this conversation, as opposed to no, I got this myself. I don't need any help. But when they may really need help if they kind of widened it a little bit.
Yeah, exactly. And one of the things, Kathy, that we've sort of really focus on is putting forward a model that really expedites the time to value and the time to financial sustainability of these programs with health systems. So we try to make it as simple as possible to launch these programs and as low risk for health systems. Knowing that, to your point, some health systems may be interested in this care model, but not really know, hey, is this going to be a scalable, self-sustainable program, at scale, knowing that, we're still putting together a payment model that makes sense. So what we try to do is really make it as inexpensive and simple and fast as possible to launch these programs, so health systems can gain confidence that they're making the right, the right decision by seeing these programs scale right before their eyes.
Right. Hey, one of the things you mentioned a little bit before is some of these hospitals are kind of doing hospital at home. When hospitals are trying to figure out do I do the waiver or do I not do the waiver? What's your kind of philosophy when it comes to inbound health and working with these folks? You do it either way, or do you guys kind of talk to them about what the pros and cons are?
Yeah, it's a great question. So we've got a pretty consultative sort of pre-contracting process with health systems. So what we'll typically do is we'll take in their encounter data, typically post-adjudicated claims data, and we will basically identify where these types of advanced care models might improve their operational and financial efficiencies, and clinical outcomes. So to your point, they may have, we have health system partners that have severe issues in their emergency department with boarded patients, and long wait times and overcrowding. And that might be a huge opportunity to focus on the waiver program and just general hospital replacement. We see other systems that might have that, or patients that are having long lengths of stay. So, for instance, in Minnesota, and this actually the Minnesota Hospital Association just published an article, I think last week, showing that 65,000 inpatient days were unnecessary over a 5-month period, in their market, and it was driven primarily by the fact that the patient sort of had nowhere to go. They were in the hospital. They had to step down to a facility of some sort. They couldn't just go home with home health. But because of capacity issues, there was nowhere to send the patient. So they were basically languishing in bed, and that creates downstream, as you can imagine, challenges. Patients that are arriving in the ED that need to be admitted can't be admitted because there's no bed available on inpatient floors. So we'll diagnose that issue collaboratively with health systems, and in that case, potentially look at deploying our sniff at home care model, because it would distinctly solve that problem. So as a part of our process, we really identify those issues collaboratively using a data driven approach, and then identify, here's where we're going to deploy, what this care model at this site, with these disease states, with these clinical champions, and here's the admission volume we think you'll see, and the representative clinical and financial outcomes. And then we put our fees at risk against the ability to do that. So we're really hyper focused on, ensuring that it's a right partnership for us and for our health systems, using that sort of data driven approach. And to your point, sometimes it's waiver only, sometimes it's waiver plus a post acute replacement, or diversion program. Sometimes it's privately contracting with a specific set of payers. And some of our health systems are deciding to do this, by creating a payment model from their home health episode and billing for the episodic video visits. So we try to personalize it to the system's needs.
Sure. Well, and I imagine it depends on size, not just of the health system in general, but the size of the hospital versus the size of the home health. Sometimes home health, especially during the pandemic, all these home health agencies developed such a great way to keep people out of the hospital, working with telemedicine, with advanced care at home programs. And when their hospitals decided, hey, we're going to do the waiver program, the home health organizations were saying, wait a minute, we got these folks at home already, and
Right.
we could prevent the hospitalization. But if you put them in the waiver program to do that, it actually technically counts as a hospitalization,
Right.
and the home health agency is going to get dinged. And so there's all these competing, stressors.
Right, right. Yeah, no, definitely. And there's definitely, what we have to do is not just develop a payment model with the plans, but even internally within the system, to your point. So we ensure that credit is being derived, or being accounted for where the value is being derived, right? So, to your point, what we sometimes see is that a patient will, whereas a patient that would have otherwise gone to a brick and mortar sniff, we're able to keep within the continuum of care of the health system. And oftentimes it's, they're going through our care model, but they're going to subsequently step down to a more traditional 30 or 60-day home health visit. That home health group, that captive home health group within the health system, may not have seen that admission if the patient had been lost, if you will, to a brick and mortar sniff. So our ability to leverage this care model to really help the health system expand the continuum of care can actually be a win-win for multiple different parties, for the home health agency that's captive to the health system, clearly to the hospital operators and financial team, and to the health system as an enterprise. And so we really try to find that model that where everyone can win, not just across the enterprise broadly, but within the hospitals and health systems themselves.
Well, that speaks to that discovery process that you were talking about. You got a lot to talk about in developing these programs, but but it sounds like you're doing a comprehensive job at that, and then try to go as fast to market as you can with them once
Right.
they've just made key decisions, because it's all about those decisions.
Yeah.
Um, and sounds like you're meeting with not just the clinical folks and operations folks, but the finance folks as well, because one of the key things we've heard a lot from health systems, especially their finance folks, is wait, if we keep them out of the hospital, we're not going to have the hospital revenue, and that's where the money is in a health system. They get a little crazy.
Yeah. Yeah. No, I mean, our experience has been, in order to launch a sustainable program, and it's not easy and it takes some time, but in order to do that, you really do need, to your point, cross-disciplinary collaboration. So we have, our work streams. We work directly with the financial leaders, with the operational leaders, and that can be everyone from the hospital presidents that hold the P&L, but certainly the folks that are closer to day-to-day care from an operational perspective, home health, discharge planners, ED physician groups, the hospitalists, the managed care teams, revenue cycle. So it really is a program that you have to engage across the spectrum of functions within a health system to make sure that it's going to be sustainable. I've always sort of thought these programs are interesting and relatively easily to, launch if you're focused on one disease state and one site, and there's a clear champion there, and you don't plan on expanding it broadly and making it self-sustainable. But if you're going to make it sustainable across time and across the entire health system, it really does require that collaboration. And one of the things that I'm particularly proud of that Inbound brings is a team that really does that work pre-contracting. So the system, our partners know when they're getting into a relationship with us and a partnership with us, that what we're going to create is going to be something very large, very sustainable, and have longevity over a number of years, and not be sort of a flash in the pan pilot, if you will.
Right. Well, and I think to that end, one of the things you didn't mention, but I think is probably a key piece of it, is the IT folks, the chief information officer, those folks who are,
Yes.
going to be worried about, all right, our patient, our record, their technology, their record, how are we going to do all this and be HIPAA compliant and avoid data breaches. How do you integrate the information that you have with the information they have and need and will need? Talk a little bit about that, because I know you've spent a lot of time talking about that with some of your clients.
Yeah, and thank you, Kathy. I was remiss. I did not mention the CIOs and the IT folks, but that is a very large work stream of work that we focus on, both pre-contract and during the implementation phase. So we have a number of different ways that we work with those teams. I'd say the first is helping them configure their EMR to be able to see these patients. You have to sort of create virtual beds and new departments, and ensure that not just from a care delivery perspective, but from a billing perspective, you're properly equipped. So we provide a lot of consultative services around that, having done that a number of times across a number of systems. We also, because we have a proprietary technology platform where we're not just capturing real-time biometrics and signals from the patient's home, but we're also conducting care. That's where our hospitalists and SNFists are virtually rounding on patients. And we're really capturing real-time data from patients, whether that's being customized surveys that we deploy to the patient's app that we are providing in the tablet that we provide, to really gauge, issues around mood and appetite and activity level, things like that, as well as the vitals, as well as information around movement and fall risk, and then the actual encounters themselves. So we work with the technology and the clinical teams to identify which of those data points would need to live in the EMR. Certainly all the encounters need to live in the EMR. So our teams are documenting directly in the EMRs that our health systems are using, so that every encounter is properly documented. And some systems want to see biometrics that are going in. Some systems want to see the results of lab tests or imaging tests that we're conducting in the home. So we will get that into the EMR. I will say, however possible. In some cases, we're working with EMRs that are a bit more extensible in nature, and we can automate the transmission of that data directly into the system. In some cases, we, are uploading it. Our teams are uploading it to make sure it's there. The important part is it should be um, seamless to our health system clinicians and partners. So that's a big piece of our technology platform. And then I would say all things that happen typically after an encounter. So there might be orders that need to be placed in the EMR. There might need to be consults that are ordered. And so that too, our teams are taking care of. And over time, we're going to integrate that and make that more automated. But as you can imagine, if we're making a commitment to fast speed to market and fast time to value, we can't let an IT integration hold us up if there is a more manual workaround. Obviously, that has to be approved by the health system and by the CIOs and to the leaders across the system. But we commit to the manual workarounds just to make sure that we can get started quickly. And then we're working with all the major EMR systems in the country to create those more seamless integrations so that our providers on our staff aren't have to necessarily in the long term work with across tens of different EMR instances.
And so you're ready, no matter what one of your new partners is on, you're kind of ready, in advance. Very
Exactly. That's exactly what we're focused on, and we put our fees at risk against that readiness. So we take it quite seriously.
Well, Dave, you mentioned a couple minutes ago, you specifically mentioned Allina, one of your key development partners and one of the sponsors of Inbound Health. And so you talked a lot about Minnesota. Um, are you kind of concentrating on building out from there? Are you kind of I know you can't talk specifically about clients, but if a health system's listening today, and they're thinking, "Wow, this is intriguing. I hadn't really talked to Inbound before. Where are they? What's your geographic reach at this point, or where are you willing or able to go at this point?"
Yeah, great question, Kathy. So we're national in nature. The whole reason why we created Inbound Health is that we could service, health systems across the country. We are implementing a second health system in the Minnesota area. So a large academic medical center that has multiple metro hospitals. We're excited to get that going in about 2 weeks from now, as well as a very large multi-regional health system across the Midwest. So 20 plus hospitals across 4 markets that they own their own health plan, and we'll be launching with them in the late March timeframe. So that's who we're implementing as we speak, and then we're in discussions with, I'd say, probably 20 plus health systems around the country, and in almost every major metropolitan market that you can imagine. And we're particularly excited to try to figure out a way. This care model has not yet been mastered, I'd say, by any of us in rural America, and so we're interested in experimenting and trying to find a way if we can bring this model in a operationally and economically efficient way that makes it sustainable for all parties into rural America too. But right now, I'd say we've been more focused in the metropolitan areas and sort of the top 25 CBSAs or MSAs across the country.
Mhm. Well, it's exciting to hear you say that. On our podcast, we've had a number of advanced care at home, acute care at home, hospital at home programs, and only one other program has said the word rural without running screaming from the room in fear. So really happy to hear you say that.
Yeah, I mean, we're saying it. We still need to prove it out. It is a hard care model. So, but we are. I mean, ultimately, that's a key need, and I think particularly for critical access hospitals that we're working with, that's going to be something that we continue to work through.
Sure. Well, and they may have some ideas because I'm telling you, you got to be really proud of those rural hospitals, and it's almost like being on the frontier in some
Right.
ways. When it's 2 or 3 hours to the closest hospital, you got choices to make. Do I send people to them? What direction do we send people in? And how do we make care as accessible as possible? So
Yeah.
really exciting to hear you talk about that.
Yeah. No, we're
Yeah.
excited.
Well, Dave, this is so exciting. What's next for Inbound Health? I mean, what's on the horizon, you know, in terms of, I know you can't necessarily talk about financing or anything like that, but, what's next in terms of big steps, if there are any, and what have I not asked you that you wish I did?
Yeah, no, great question. I mean, ultimately, Kathy, our vision is to enable these care models for 100 million Americans across the United States. And so we've got really big plans to try to enter multiple markets across the United States, and excited to work with health systems. We also know, from all of our conversations with health systems, is that the advanced care model, frontier, if you will. We talk a lot about hospital home, and we talk a lot about skilled nursing facility models at home, and those are great, and those will continue to be our flagship models. But there's other advanced care models that we can bring into the home. Certainly, emergency care in the home, primary care in the home, oncology care in the home, even chronic disease management and remote patient monitoring. And when we're talking to our health system partners, they're really focused on, I need to have one partner that brings all the enabling capabilities for that. I don't want to have different partners for each one of those. It gets very confusing and difficult to scale. So we're working with our system partners to really build out our capability set to make sure that we can power all of the advanced care models, that can be deployed to use the home as a care site as much as possible. I'd say on the payer front, we are very excited to move our care models to make them as value-based in nature as possible with the payers. So we've done a deep actuarial study. I think it's probably the only one that's ever been developed for both hospital and SNF at home, and have identified the cost savings and the accessibility of these different care models, and have worked with our payer partners to bring that forward. We think that that's a very compelling and necessary model. I think anyone who's looked at some of the payer press releases over the past sort of 6 months probably noticed that hospital utilization in general, facility utilization is very high. It's weighing on medical benefit ratios. It's weighing on some of the Medicare Advantage plans, financials. And the beautiful thing about these care models is they really are win-win-win. They're win for the health systems, they're win for the payers, and they're wins for the patients. And so we're excited to more deeply work with a lot of the payers on developing a sustainable financial model for commercial Medicare Advantage and managed Medicaid lives, but ultimately moving that to an aligned economic model where we can where we can align their interests with the health systems and the patients. And then obviously, I'd be remiss if I didn't plug. We're very excited for what we hope will be an extension or a permanent placement of the waiver program that CMS has put in place. We, like many of our partners in this market, and a lot of the health systems that were earlier to the game and are truly frontiers in this area, have seen a ton of value around the waiver program, and are excited to see a way that gets extended beyond 2024 and hopefully becomes a permanent part of the Medicare benefit. So we're excited to participate in that national conversation to make that happen.
Nate. Well, I think you just gave me the lead in for the invitation to come back again. So many exciting things with the payers and an expansion, and the idea of additional specialties in the home. It sounds like we've got to get that invitation out to you at PDQ for the future. Dave,
Anytime. We'd be
Dave,
honored to come back.
excellent. Well, thank you so much for joining us today to talk about Inbound Health and your model and your journey. And we look forward to having you back again. And thank you to all of our listeners. We look forward to seeing you again on the next episode of Bringing Care Home.
Thank you so much, Kathy. It's been an honor and a pleasure to be with you today.